Good morning, friends. At the outset, let me congratulate Dr. Dumra and management and consultants at KD Hospital for organizing this very efficiently organized and academically rich feast in the field of pulmonology with a little bit sprinkling of thoracic surgery. Also, heartiest congratulations to you, Dr. Dumra. And also, thank you very much for including this lecture on thoracic surgery, and that too choosing the topic as innovations rather than the conventional run-of-the-mill. But before I go into lecture, let me bring you greetings from All India Institute, Gangaram Hospital, and Medanta Hospital, the three hospitals that I have been very fortunate to be associated with. I also bring you greetings from my team of Dr. Bilal, Dr. Harsh, Dr. Sukram, Mohan, Sumit, and Manan, the 7 consultants which today form the largest thoracic surgical unit, which is not only a clinical unit, but also runs an academic program of DNB with an annual intake of 3 students per year. Thoracic surgery started with this gentleman, Dr. Graham, performing a pneumonectomy in 1933, which was a very crude form of pneumonectomy that he performed. But from that very primitive stage, we have come a long way in doing the surgery the way we do today, from a time where this was actually feared with large number of patients dying of the surgery rather than the disease. We have a stage where sometimes we are now even talking of doing this as a daycare surgery. So when I thought, what all things, there are so many developments which have happened. It's not possible to put everything in a 20 minutes lecture. So I thought, let me divide them into categories. Something which is very much there on the ground, that is changes which have happened in the field of surgery. Something which is now getting more and more incorporated, more on your side, pulmonology side, but also has a role on our side. Something which is now coming up as something which started from lung transplant, but is probably going to find more and more applications. So this is there really. This is also coming up. This is going to come up in next few years. And finally, end will something which sounds like fiction today, but maybe when Dr. Dumra holds his next meeting or next to next meeting in 2033, this might be a reality. So coming to first one, the surgical revolution, which is already there, which has actually changed the way thoracic surgery. This also has lot of developments. Again, I can't put everything there. So I thought, okay, minimal invasive has been termed the third revolution in surgery. The first was discovery of asepsis, which actually made surgery what it is today. The second was discovery of anesthesia, which brought a humane angle to the surgery. And third is development of minimal invasive or minimal access surgery, which is actually possible because of the development of a camera, instruments, devices, various other things, which I'll briefly touch upon. Then there is an entity called non-intubated surgery, where elderly people are now having local resections in the lung without being intubated, or also called awake non-intubated surgery, which is allowing these patients to be discharged very quickly with lesser complications. There is a huge shift now in the way we operate, from a time where pneumonectomy was actually one of the commonest procedures. Today, we realize that pneumonectomy is not a procedure, it's a disease. You take away one disease of the patient, but give him another disease. So there is a lot of stress on reconstructive techniques to somehow save some part of the lung by implanting the lung somewhere or the other. Then there are some approaches in specimen removal, etc., which have come up. The major change which happened, which allowed minimal access surgery to develop, was that the big camera which we all used to carry at that time was miniaturized into a small 2 by 2 or 2 by 3 inch size, maybe 200-gram device, by the development of this charge coupling device, which allowed the camera to be miniaturized and put at the end of a telescope. It's not that endoscope did not exist. Endoscope existed before that also, but then through the telescope, only one person could see, and therefore there was a limitation to what you can do. But this camera being put on the end of telescope allowed the image to be projected onto the screen, allowing the possibility for everybody to be able to see, and therefore many more therapeutic procedures started being done. So this was the most significant development. But coupled with this development, there were developments in instruments. Newer and newer instruments came. There was development in stapling devices, because if you were to try and suture the lung inside, you would lead to a lot of air leaks and morbidity post-op. But with various kinds of stapling devices which could selectively staple vessels, lungs without air leak or without blood leak, a lot of surgical options became possible. And side by side, when you have to lyse adhesions, when you have to cut the tissue, if you were to just cut and bleeding be there and you're trying to control the bleeding by suturing, it would waste a lot of time, but a lot of energy devices became available. For example, bipolar cautery, harmonic scalpel, ligature, all these allowed a lot of dissection to be done in a bloodless manner. So ladies and gentlemen, starting from miniature camera to development, all these equipments and instruments allowed what we call today as video-assisted thoracic surgery. And starting from this big thoracotomy, which was the standard of care at that time, there was a series of developments which took place. So from this, we went to multi-port video-assisted thoracic surgery, where you put a telescope through one of the ports, you put 2 or 3 more ports. You don't do rib resection, you do the entire procedure without rib resection, thereby saving a lot of trauma to the patient. Came the robot, and the robot was added to this. So this was called multi-port video-assisted thoracic surgery. And when the robot came between the surgeon and the patient, this was called multi-port robotic-assisted thoracic surgery. Some people said, what is the need to make 3 incisions? Let's get all the 3 incisions into one. What was called uniportal. There is a debate whether this really offers an advantage or not, but nonetheless, this is something which is coming up. So multiportal VATS became uniportal VATS, and the robotic company said, why should we be lagging behind? We are also coming up with new instruments, so the multiportal robotic assisted became uniportal. So ladies and gentlemen, starting from a big incision with thoracotomy, rib retraction being the bane of thoracotomy, we have multiport VATS, multiport RATS, uniportal VATS, and uniportal rods. These are the developments which have happened in the field of surgery. And this has led to opening of a whole new vista where a lot of procedures have been done. When you look at VATS, you find there are so many advantages. And then a thought comes to your mind, with all this, everybody should be doing it. But when the ESTS, European Society of Thoracic Surgery, and also American Thoracic Society looked at the data, they were shocked to find that not more than 1/3 of the resections in these countries also were being done VATS, and the reason was that there were a lot of technical difficulties in VATS, and people were finding it difficult to learn it. And therefore, a main thing was that you have 2D vision, you have lack of touch sensation, and the instruments, which are straight instrument with no joint there, were posing limitations in doing procedures, and therefore, robot was added, which allowed 2D vision to be replaced by 3D vision, the instruments to be more versatile, being able to access the inaccessible area, and suturing, which was the difficult aspect in video-assisted thoracic surgery, became very easy here, along with all other advantages of minimal robot surgery. And therefore, from thymectomies, pneumonectomies, mediastinal tumor, dissection, esophagectomy, to virtually any and every procedure today can be done by VATS if you are proficient. And if you are less proficient, you get the robot, and the robot will allow you to do that procedure with that. So single port, haptic feedback, that is touch sensation, is something which we have not yet got in the robot. but otherwise all advantages are there. But the camera and telescope was still quite a bulky thing. So there is something new which is now being developed called Magnetic Anchoring Guidance System, or MAGS. It's not yet in clinical practice, but it's something which is coming up, in which you put these small cameras on inside of the chest wall. One, or sometimes you can even put multiple small cameras. So instead of a big camera and a big telescope, now you have this camera fitted inside the chest wall, and you get a much better view of inside of the chest. So instead of all this device, you will have the field totally uncluttered. It's still in developmental phase, but maybe in times to come this will become. When robot was being used, we were using only the mechanical part of the robot. So people said, why not we use the brain also? So get the ultrasound image, CT image, MR image, PET image, make a virtual patient in the computer of the robot. Let's do a virtual surgery on the software, and then get a virtual specimen, do a virtual pathology, and then go and do the surgery. And people went one step further. Okay, having done all this, save it in the form of a software, and then why surgeon should sit? If everything is fine, you make it into a file, press enter, and as per the commands, the computer can do the surgery. So virtual reality is also now getting integrated into the robotic surgery. Again, I must confess that as of today, this is something which is in experimental phase, but maybe 5 years down the line, all this will become reality, and we will see a lot of surgery being done not with the help of the robot, as is the case today, but by the robot, as directed, dictated, recorded by the operating surgeon on the computer of the robot. So this was one. Now, patients are being operated without intubation, so that's another area. And then, as I said, there are a lot of tumors of the carina, right main bronchus, left main bronchus, secondary carina, particularly on the left side. You have lobar tumors which are reaching up to the secondary carina. So let's say you have a lower lobe tumor which is reaching up to the secondary carina and also involving the proximal part of the upper lobe bronchus. Typically, today these patients are subjected to pneumonectomy. But what you can do now is to cut the distal left main bronchus 1 centimeter away from the tumor, cut the upper lobe bronchus 0.5 centimeter away from where the tumor is coming, remove the lower lobe which is containing the tumor, and anastomose the upper lobe to the left main bronchus. Similarly, you can anastomose lower lobe to the left main bronchus. If it's only Y, secondary carina, which is involved, you can create a neo-secondary carina by joining the upper lobe and the lower lobe and join that to the left main. Similarly, on the right-hand side, if it's a right upper lobe tumor coming into the right main bronchus, obstructing right main bronchus, people will do pneumonectomy. There is no need. You cut the main bronchus proximally, cut the bronchus intermedius distal to the upper lobe, and join the proximal bronchus to the bronchus intermedius, doing sleeve lobectomy. Similarly, if it's a middle lobe tumor coming into the bronchus intermedius, again, you can remove middle lobe with a cuff of bronchus intermedius, join the distal bronchus to the... So there are a lot of these tailoring techniques which can be done, where you can reimplant the upper lobe, middle lobe, lower lobe, left upper lobe, left lower lobe onto the main bronchus or onto the trachea, thereby trying to save at least a lobe. If you can save a lobe, you are not giving a disease to the patient in lieu of the disease. If patient comes to me with carcinoid left main bronchus, you do a pneumonectomy, you've taken away his carcinoid disease, but you have given him another disease called pneumonectomy. So ladies and gentlemen, this is a very, very big development in thoracic surgery, and I'm happy to report we've been in the forefront, and we have 5 major publications in index journals on carinal tumors, carcinoid tumors, mucoepidermoid, and numerous other tumors where different types of these kind of procedures have been done, thereby saving the lung parenchyma. And lastly, when you want to remove the specimen, you can do a subxiphoid. Next is navigational bronchoscopy guided surgery, which I'll skip because time is short and this is precisely your area. But navigational bronchoscopy, endobronchial ultrasound, now being combined with thoracic surgery also in the form of an intraoperative help, offers new vista for a lot of new things to be done. Indocyanine green or other dyes which can be incorporated into this system, thereby giving you better tumor margins, thereby allowing limited resections to be done, is another beautiful area which actually needs to be explored. Now coming to a very interesting concept called isolated lung perfusion. Now, this is something which started from the field of lung transplant, where University of Toronto group observed that if you have a patient who has a marginal lung, where PF ratio is less than 300, this is not optimal lung. But if you get this lung, you connect it to a machine and perfuse this lung with an acellular isotonic solution, and also ventilate it with a 21% FIU at a low pressure for 6 to 8 hours, 40% of these marginal lungs get converted into usable lungs, thereby increasing the organ availability. This is called ex vivo lung perfusion. So you get these lungs, you connect it to the ventilator, you connect it to a pump where a steam solution, which is an acellular isotonic protein containing solution, is perfused through this at a low pressure for about 6 hours, and 40% of these marginal, non-usable lungs can become usable. There are commercial machines now available. This was called ex vivo lung perfusion. The same Toronto group went one step further and said, why can't we do it in the form of an in vivo lung perfusion? So you have a lot of patients with metastasis, colorectal, or other metastasis to the lung, where resection may not be possible. You may not give very high dose chemotherapy because of the systemic side effects, but if you put a catheter into the pulmonary artery and you drain the blood from the pulmonary vein, connected to this system, so you've isolated the lungs from the rest of the body. This is called in vivo lung perfusion. You can subject the patient to a supra-pharmacological dosages of chemotherapy, thereby achieving good cancer clearance. So ex vivo in lung transplant setting and in vivo in the setting of thoracic oncology is again a very promising development. And lastly, something which sounds like fiction today, tissue, lung bioengineering and tissue regeneration. So there is lung is a very immunogenic organ. Biggest problem after lung transplant is immune rejection, for which you give the medicines to reduce immunity, but the side effect is infections. Could there be a possibility you fit the lung and forget about it by making it non-immunogenic? So people are working that let's take the lung and decellularize the lung, leaving only the acellular soft tissue network. Get donor cells and repopulate this acellular network with donor cells. So this will not have immunogenic potential. People have gone one step further, that instead of taking the donor lung, why not we have an artificial substrate created, so that scaffolding, instead of taking from a decellularized donor lung, you take a totally artificial, populate it with patient's own multipotent cells, and get a lung which has viable lung function but is immune neutral because it's all patient cells. Ladies and gentlemen, this is a total experimental work today. But lot of things which are reality today were experimental at one time. And as a lung transplant surgeon, my wish, my dream, my hope, my prayer is that this comes true one day, where, as I keep saying to my colleagues, let's have a situation where you get the lung, do some process in the form of ex vivo lung perfusion, go fit it into the patient's lung and forget about it. No immunosuppression, and therefore no risk of infection and no follow-up. And there's a fit it, forget it. Well, if progress does happen on this front, this will allow this dream to become reality one day. So friends, I've given you an overview. There have been developments in surgical field, because of minimal access camera, energy devices, etc., which is allowing video-assisted thoracic surgery, multiportal, robotic surgery, uniportal, multiportal. There are navigational bronchoscopy and other developments. There are developments in the form of ex vivo lung perfusion and in vivo lung perfusion. And there is this futuristic area of lung tissue regeneration and bioengineering. Thank you very much for your time and attention. Thank you.